me? Yes. Okay. Hi, everyone. I'm Preeti Coffin. I'm with UCB Pharmaceuticals, and it is my pleasure to introduce the ultimate treat of Halloween, Dr. Adam Numis. He joins, I know, right? He joins us from UCSF Benioff Children's Hospital. He is a pediatric neurologist there, and he specializes in epilepsy. He focuses on evaluating and caring for children with epilepsy, particularly children and adolescents with difficult to treat seizures. He is also working to improve diagnosis, treatment, and outcomes for infantile spasms, a particularly severe type of epilepsy. Dr. Numis has received his medical degree from Harvard Medical School. He completed a residency in pediatrics at Boston's Children and residency in child neurology at UCSF, and fellowships in clinical neurophysiology and epilepsy at UCLA. Dr. Numis, it's all yours. Thanks for being here with us. Would you like this mic?
Sure, thank you. Perfect. So I was going to make this pretty informal because I think it's way more fun for you guys to ask questions rather than me presenting again, because I know you guys have been seeing lots of presentations today. But I'm also happy to cover some of that as well. I wanted to kind of think about this in a couple different sort of packages of questions, just to kind of help frame everything and kind of where we might want to go with some of these topics, but please feel free to ask anything about anything. That's totally cool. So with early epilepsies, right? So we think of them in a couple different ways. You have sort of what we call neonatal onset. These are typically the seizures that happen within the first month of life. Then you have that infantile onset, and that pretty much covers anything from this up to 2 years. And so in thinking about this, the different kind of topics to kind of think about are how we diagnose these, how we treat them, and then how do we know how kids are going to do? And I'm happy to kind of go into different things like the tests we try, what kind of tests are coming out soon, sort of research kind of discoveries that are happening. The same thing for treatment, so kind of the standard ones, which ones are, this includes surgery, but also the new clinical trials and the new kind of investigations that are going to be coming out over the next few years. And then sort of outcomes, kind of how do we predict who's going to keep having seizures? How do we understand who's going to potentially do better with one medication versus another? So all those kinds of questions and things. So opening up to you guys, because this is really kind of question-based again. So it's you guys asking questions to me, and then I'm happy to show you some slides if that's helpful too. Yes?
I do pediatric neurology referral triage, and so for me it's difficult to assess what is like an emergent infantile spasm designation versus like a neonatal that has like a myoclonic germ or something. Like how to escalate, how to triage it urgent versus like needs to be seen within a day or within 3 weeks.
It's really hard, right? And even with videos, we know that videos are pretty bad. Even if you take 100 epileptologists and you show them videos of kids with infantile spasms, we're gonna miss, a bunch. We're gonna miss 25 out of 100. We know that. And so it's, if it's in the right age range, right? Typically we think of infantile spasms happening from as early as 3 months, usually up to a year, but it can extend out to a year and a half. But if you have someone in that 3 to 12 month range, I think you have to do it urgent and expedited, because even with videos, it's hard to triage. Any other questions? Yes. Yeah, so the question was, so for someone who's been seizure-free for 4 years, when's a good time to ask your doctor about when to come off medications? And it's a great question, and in this particular case, it sounds like their EEG still is abnormal. And so there's really good data from 15, 20 years ago that is pretty much what we rely on. There hasn't been anything newer since to really help us with this. So we know that if you can go 2 years without seizures, then you have a pretty good chance of potentially coming off medications. In the best case scenario, it's still only 70%. So that means 3 out of 10 kids, even in the best situations, will still have seizures recur. If you have an abnormal EEG, or depending on whether the MRI is abnormal and how it might be different, that drops you down to 50%. So then it's kind of flipping a coin, 50-50, whether or not you'll be able to come off medications successfully. But it's certainly always worth a try. And I think, again, this is the best data we have, and it's from a little while ago, but no one has been able to really do this on a bigger kind of scale. And part of it is funding. It's really hard to do these kind of studies. It takes a lot of different centers, and it takes a lot of money to do. But based on that, I think it's 50-50. The good thing to know is even if it doesn't work the first time, like let's say someone comes off medications and then they need to go back on, you can still try again a couple years later. And sometimes we often have to wait until kids have reached puberty and kind of go through puberty, and then that might be a better time as well. But not having it work the first time, still can try again. Great question. And with infantile spasms, it's a little harder. We don't have a ton of data on that either. We know that we give people treatments, we get people off of treatments quick, and then we know that there's some kids that will have recurrence of spasms in some of these earlier onset epilepsies. There's a clinical trial that's going to be starting that's looking to see if you can give someone low doses of a medication every day to see if you can prevent the spasms from recurring during that time frame where they're most likely to occur, which is the first 6 months. Thank you, Mary. I just turned it around and it seemed to be okay. Thank you, yeah. Awesome. Yes?
In regards to like HIE neonatal seizures, what is the outcome of, or I don't know if you know the statistic of how many of those patients are seizure free as even children, small infants or children?
Great question, yeah. So I am gonna use a different color marker for that. So the question was, in babies with hypoxic ischemic encephalopathy or brain injury from a lack of blood flow or oxygen to the brain, how do you know who's going to have seizures after that? And then, I guess, how do you treat them, right? So, I'm just going to abbreviate it, HIE. So, HIE is it's not uncommon. Again, it's usually either the placenta is having a tough time getting blood to the baby, which can cause some issues getting oxygen and blood to the brain, right? And the way we actually treat it in this country, in developed countries, is by using hypothermia. So we chill the babies to about, it's in the mid-90s, essentially. So low 90s, you cool them for 3 days, and then you stop and rewarm them up, and that is actually protective. It keeps any additional brain injury from happening. During that time, there's still some kids who will have seizures. About 15%, so about 1 in 7 kids have seizures, even with the cooling. And then of those, if you have seizures, about 1 in 7 will have epilepsy later on. So depending on how bad the injury is or how severe it is, sets you up for different potential risks of seizures. And then about 1 in 7 kids will have epilepsy. We don't totally understand why. A lot of the research we're doing now is looking at this. So after this, why do some kids have seizures and others don't? And if you do have seizures, why do some of them develop epilepsy and others don't? What we're finding is that it seems to be related to, one, genetics. So just like some people are at risk for having high blood pressure or diabetes, other people are at risk for having epilepsy. So if you do enough stress on anyone, they'll have a seizure, right? If you sleep deprive someone for a few days, dehydrate them, all those things, anyone could potentially have a seizure, right? It's just some people have a higher predisposition towards seizures than others. And so after some sort of brain injury, you can imagine your genetics kind of predispose you potentially to that. And then the other part is, inflammation. So we have a lot of really good data now from large clinical trials that show there's an association of inflammation with sort of how this curve works. So that these seizures produce inflammation in people who are at risk. So it seems like there's a genetic predisposition towards a pro-inflammatory state, and those are the kids that get seizures. And then for those in whom the inflammation continues to stay elevated, those are the kids that seem to have epilepsy. A lot of that is still research-based, so the best we have is essentially if it's a baby with HIE who have seizures, they're the highest risk of developing epilepsy after. The initial seizures are really just a symptom of the brain injury itself, but we know that those kids are at the highest risk. So at our center, we see them at 3 months and then again at 6 months. But while they're still in the hospital, we talk to them about infantile spasms because occasionally, if you do a 3-month appointment, if they're 4 months old, right, that's in the kind of time window, they may already have spasms. So we do the counseling right at the beginning to make sure that the parents hear it, they see the videos, and if they do notice it, they can let us know right away so that even if they're a little off with that 3-month appointment, we can get them in as soon as possible.
And those babies put on ACTH?
Yeah, so that's a great question. So I'm gonna use this side now.
Is it dry?
Yeah, it's we'll see. We'll take some elbow grease, I think. Thank you, Mary. Mary is is the head of our EEG at UCSF. Oh, it is pretty on.
I just threw away the button.
That's okay.
All right.
Oh, yeah, perfect. Yeah, thank you. That's perfect. Thank you so much.
It's a team effort.
Thank you. Okay, so infantile spasms is one of those epilepsies that is treated a little bit different than all the other epilepsies out there. And so for infantile spasms, one of the first, does anyone know how infantile spasms was first discovered? It was actually a surgeon, a cardiothoracic surgeon, whose son had infantile spasms back in the 1860s. And he wrote an article asking other physicians for help, essentially. So it was published in a journal, this description of his son who was having infantile spasms, and it was just basically an open, help me, what do I do? So we didn't really have any good treatment until about 1950. Up until then, everything that was used for other seizures wasn't that helpful. And so in 1950, ACTH was tried in these kids and was shown to be effective in stopping the spasms. And just real quick, if you've noticed, the name has changed from infantile spasms to infantile epileptic spasm syndrome. And this happens every 5 years. A group of people get together and they change the names to make it very confusing for us, everyone. But now it's infantile epileptic spasm syndrome. Everyone knows what you mean though when you say infantile spasms. So 1950 ACTH, first treatment that we ever found that was really helpful for these babies, for these kids. Since then, so since 1950 to 2023, there's only 3 treatments that really are helpful still, and one of them is still ACTH. The other is steroids, and the other is vigabatrin. So what we do know is that ACTH and steroids are about the same when you look at large clinical trials that are done in Europe. They haven't been done in the United States. And the reason is it's not like we don't want to try, it's just a funding thing. No one really wants to fund us to do it, so we have not been able to actually get it done. Yeah, actually, I'll take a little bit more. Thank you. Thanks so much. Thanks. ACTH is great, but it's an injectable medication you have to give twice a day. So it's not a lot of fun. So what we do know is ACTH and prednisone are about the same Maybe ACTH is a little bit more effective, but probably within 5%. And then, unless you have a condition called tuberous sclerosis complex, TSC, these kids with this particular epilepsy respond really well to vigabatrin, which is just it's a type of medication particularly helpful for spasms, not helpful for many other seizures. So we know, so over the, 73 years, we basically have gotten this far. This is it, that's all. An active area of research that I do is trying to come up with new drug treatments for this, but we're expanding our research kind of and doing a multi-center kind of thing pretty soon, but it's just basically going door to door and asking people, different agencies to help fund it so we can try this stuff. So we know ACTH and prednisolone are about the same. We also know that ACTH plus vigabatrin, giving both at the same time, or like steroids, prednisolone, plus vigabatrin, is more helpful than either alone. If you look at 4 weeks, more kids are going to have fewer spasms at 1 month. But the problem is these kids have a lot more side effects, and so far it doesn't seem like it changes outcomes in 2 years. So we're waiting for the 5-year outcomes from the European study group, but at the moment it seems like the combination therapy, although it's more helpful initially, may not be as helpful as we thought it may be in 5 years. So we're still waiting for that data before we kind of fully figure out kind of what kind of therapy to use. So to get to your point, it's still argued. People get really worked up about it. They're about the same. So it just depends. People have different sort of institution protocols. We're doing a study now where we're collecting all the protocols from every different institution in the United States to just try to see how many people are doing this, how many people are doing this, how many people are doing this combination thing, just so we can see. Again, without great data, we're just going to say, okay, well, if 90% of centers are doing one thing and 10% are not, well, it just is helpful to know what those kind of patterns are.
And what are the outcomes for this?
Yeah, so it depends when you look. So if you look at 2 to 4 weeks, about 75 to 80% of people respond. Okay? At 2 weeks. If you look at 6 months, it's about 50%. Right? And the issue with infantile spasms is every month that they continue to go on, about 8 IQ points is what you lose. So it's one of our more urgent kind of epilepsies to treat and get under control quickly, because we know the longer you have them, the worse it is for your overall brain function moving forward. And so yeah, if we could get this closer to 100%, or keep that from being 50% and make that a lot higher, it would be great for all of us, right? And that's a scenario we're actively trying to figure out. Any other questions with infantile seizures, inflammation, baby seizures, any of those things? Yeah.
When would you initiate a genetic test? Like between 3 to 6 months?
I do it actually right from the get-go. So with infantile spasms, there's over 200 different causes. Hypoxic ischemic encephalopathy is a common one, but we know that about 25% of kids will have some sort of genetic change that predisposes them to having seizures. And so I do it pretty much from the get-go. If their MRI is very clearly one particular thing, then there's your answer. So I'll do an MRI first. And then if the MRI isn't showing exactly what's causing it, then I'll send a genetic test immediately after. Great questions. Yes?
Can it be difficult to recognize maybe going through like a seizure or something?
Yeah, great question. So the question was, is it difficult to figure out whether a baby or an infant's having seizures? And the answer is yes, 100%. So for infantile spasms, right? Already said, so these are a type of seizure where it can be pretty dramatic appearing, where the head drops and the arms go up, or the head flexes backwards and the arms go up. But it can also be very subtle. It can just be subtle eye opening, right? That might be your only cue. And that happens especially after you use treatment. So the difficulty with this is once you think they're gone, they're still there about 20% of the time, 20-25% of the time, right? So without an EEG, it's almost impossible to say that they're totally gone. And you need to do an EEG. These are the types of seizures that mostly happen when you wake up or are falling asleep. So you need to get an EEG that actually has the child sleeping to figure out if they're really gone. The problem is when you give little kids ACTH or steroids, they kind of get very angry, right? I don't know if anyone has asthma, has ever been on steroids, but they cause you to want to eat a lot. They can make you very agitated, and so it's hard to get kids to sleep with just 30 minutes or an hour of an EEG, and so we often have to do EEGs for longer periods of time so we can really figure out if they're having them when they wake up still. Again, it can be really subtle. 20-25% of the time, we have no idea unless the EEG's on. It can be that subtle.
Is that what they call like absent seizures?
Those are different, yeah. So those typically happen a little bit later on. These would be called subtle spasms. And the difference is absent seizures are when you kind of stare off, what we say in medicine is a behavioral arrest, meaning you're there, but you're not there, right? And those can last anywhere from 10 seconds, 30 seconds, usually much less than a minute. These are seizures where they happen over and over. They're quick. They're only a few seconds long, but they happen over and over, usually over the course of a few minutes to up to 30 minutes, and they go back to back. Sometimes every few seconds, sometimes every couple of minutes. But they're quick, and you're with it during it. In between, the kids are still kind of there. What happens is, if you get them to be responders, those are the kids who have the best chance of not developing other epilepsies. But infantile spasms, or epileptic spasms, are a type of seizure that mostly affects kids between 3 months of age to 2 years. After that, you can still have them, but in the kids who aren't responding, they'll often transition to other seizure types, the most common being tonic seizures, where your whole body kind of stiffens. And so it's not that they go away, they can transform into other seizure types. And the kids who are not responding to the initial treatments are the ones who are more likely to have that kind of transition to something else. And so it's not that you grow out of it, it's that your brain changes, right? There's a big difference between a 3-month-old and a 2-year-old, right? We know that just from the way they grow. And so there's a lot of changes that happen with your brain chemistry and your brain receptors, and we think that's probably why this particular seizure only happens in that one time during your development, right? And then as you age, you can transition to other seizures.
So if the parents visit when they're babies, then
Parents don't typically miss it. What typically happens is that they'll see them, they go to their primary care doctor, they're diagnosed with reflux, and then a month later, they'll be like, well, something's wrong. Moms always know, dads usually know as well, but moms definitely know. And then eventually, it sometimes takes time to get to the right kind of person to figure out what the diagnosis is, but people usually push. I think there's a lot more awareness that's happening in pediatric centers to try and do outreach so that pediatricians, every pediatrician has a better understanding of this. It's been a big push over the last 10 years through the American Epilepsy Society and the International League Against Epilepsy. Those programs have been great and have certainly decreased the amount of time to getting a diagnosis. Because we know one of the biggest predictors for who's going to respond or not is how long it takes you to see somebody. If these are going on for a few months, you're much less likely to respond to the first treatments than if you catch it within the first month. Parents always know, but it's sometimes you have to push for other people to kind of get to be on the same page as you. Yes?
Is there any or some known triggers for this episode of spasm or seizure?
Yeah, great question. So the question was, are there triggers for why some kids develop this severe type of epilepsy? Great question. It's what my whole research is about. So right now we have kids who have HIE, so we know that a portion of them will develop infantile spasms. And what we do is we check blood markers over and over to try to see if we can figure out why some of them do and others don't. Again, we think it's probably related to your genetics, having a predisposition towards it, plus having some sort of trigger of inflammation. That combination then triggers it. And so what we did right now, we look in the blood, where we just measure these different proteins in the blood. So these inflammation proteins we measure. So what we've shown is that you can find these inflammatory proteins and they'll tell you pretty accurately who's going to develop epilepsy, these spasms, and not. the difficulty is we have to do it, we're going to be doing it in a larger group if we get the money from the government to do it. But that's the plan. The other thing we're looking at, well, you can say, okay, well, it's in the blood, that's not really the brain. So what we're also doing is when you get blood, I'm not an artist, obviously. If this is one of those tubes of blood, what we're able to do now, so instead of just looking in the blood and looking for these proteins, what we can do is we can separate out little bits of stuff that come from the brain, open them up, and then look at the proteins inside there. So what happens is your nerve cells, my artistry is not great, but your nerve cells actually communicate with each other with these tiny little packages called extracellular vesicles, and these can cross right through your brain into the blood. And so these get into your blood, and what we can do now is separate them out, open them up, and then look at how these inflammatory proteins are happening from cells. Because we can say, okay, well, because this has neuron signatures or neuron proteins on it, we know that that's coming from your nerve cell. That's coming from the brain, because your liver doesn't produce it. So this is the next step of really trying to prove that these different inflammatory pathways are what are associated with this, and if we can show they're coming from the brain, then we can say, well, all right, instead of using these crazy anti-inflammatory drugs from the 1950s, why don't we try something that's a little bit more specific, right? These are really helpful, but they have tons of side effects. And so if we could do something that's a little bit more tailored to the actual inflammation that we're worried about, then that would be ideal, right? Everyone in rheumatoid, if anyone has a family member with rheumatoid arthritis, you'll know that this is what they did 20 years ago, right? All they had was ACTH and steroids, and then methotrexate and a couple other things came along. But really what's been very big in changing inflammation in people with arthritis has been all those new kind of what we call biologic agents, like infliximab, lots of very long names that are hard to pronounce, but you see a lot of commercials for them, right? And so we're trying to show that if those same pathways are changed in these kids, then we could potentially use those very targeted treatments, which don't have as many side effects as just using high doses of steroids or things like ACTH. We're getting there. Give me like 5 years. We're working. When I'm not doing this, I'm basically asking the government for money to keep on trying to get this stuff going.
Can you speak a little bit about like a 10-month-old with leg jerking and how you would go from figuring out that was a generalized epilepsy versus an infantile spasm, and maybe what the percentages are of?
Yeah. So the question was, in a 10-month-old, let's say you have a 10-month-old and they're having leg jerking, how do you figure out if they have seizures, A, and then B, if they do have seizures, what kind of seizure it is, right? So leg jerking in a 10-month-old, right? The only way to do it is with the video EEG, right? Sometimes videos, like I said, can tell you. Sometimes videos for leg jerking can be very helpful because they can tell you with the video, you can say, okay, this is something totally different, or this could potentially be a seizure, in which case we need to do a video EEG to figure it out. And then it's really only the EEG that can tell you whether or not it's a focal epilepsy coming from one particular part of the brain, or a generalized epilepsy coming from lots of different places in the brain, or the whole brain kind of itself.
An infantile spasm EEG would look different than a generalized epilepsy EEG?
Yeah, great question. So infantile spasms, the question was, does EEGs and infantile spasms look different than generalized epilepsies? And they do. The EEG in kids with infantile spasms has a very particular kind of signature, and that's called something called hypsarrhythmia. People have debated how to spell this for like 45 years. It's crazy. Some people use one R, some people, it doesn't matter. But just like people change the name of this, people try to change the spelling of that. So EEGs, we all know, look for seizures, but between those seizures, they can also kind of look at how the brain's communicating with itself. So EEGs, I like to think of them as measuring electrical activity of the brain. Brain cells communicate with electricity just like wiring in the walls. And so this EEG is not just looking for the seizures, but it's looking at how the electricity is communicating and circulating between all the different parts of the brain. And that can actually give you hints as to where the seizures might be coming from and also what kind of epilepsy someone has, right? So just like if there was a bunch of short circuits happening behind this, right? The seizures are probably coming from here, right? Electrical fires or seizures are coming from behind here. It's possible they're coming from over there, but if there's a bunch of short circuits here, probably here, right? And so the pattern of short circuits can really be helpful in helping us understand what kind of seizure someone has, where they're coming from, but also what kind of epilepsy they have. So that in-between stuff is very important as well. Maybe not as important as what the seizure looks like, but can be very helpful in figuring out what's going on. Hypsarrhythmia is this pattern in between the seizures that's very particular to kids with infantile spasms, and you can see that right away on the EEG, so within minutes, typically. Usually it takes some time before you get hypsarrhythmia. So now that we've been doing this big push, right, we want every pediatrician to know what infantile spasms are, don't diagnose it as reflux, get them in as soon as possible. Well, now we're seeing kids really early on, right? So kids aren't having spasms for a month or 2 months or 3 months. And so we're actually catching them before this even develops, which is great, but it does make the diagnosis a little bit trickier sometimes.
And then what's the percentage of kids under 2 with seizures that are infantile spasms?
So overall, spasms is a rare type of epilepsy. So rare in that it's about 1 in 5,000 people will have infantile spasms, whereas epilepsy is about 1 in 100 people. So 1% of the general population has epilepsy, roughly, right? Whereas this is 1 in 5,000, infantile spasms in particular. So it's rare, but it's certainly, if you think of how many people live in California, that's, a couple hundred cases a year. Are those numbers okay? That help?
Yeah.
Okay. Yeah. Yes.
With children with infantile spasms, how often do they have West syndrome?
Great question. So this staff physician I was talking about was Dr. West in 1868. So he was Dr. West. He was the one who asked his colleagues, what do I do with my son? How do I treat this? So he was West. West syndrome is the constellation of hypsarrhythmia, epileptic spasms, and having some type of developmental regression where you lose some skills, right? It's a term we try not to use as much anymore because, again, we're trying to get kids before all that happens, right? As soon as they have epileptic spasms, right, we don't want to wait 2 months until they develop hypsarrhythmia, lose 16 IQ points, and start losing skills. So since we're pushing so much to diagnose this earlier and earlier, get people in to the clinic, get them referred for video EEGs, kids don't meet that criteria of true West syndrome because it doesn't have all the components. So this is why we've now kind of moved it to infantile epileptic spasm syndrome. It doesn't roll off the tongue very well, but this is where we are. I'm sure the name will change again in 5 years. So.
I've read some literature that link Lennox-Gastaut with West syndrome as well. Can you talk a little bit about that?
Yeah, so I'm going to change colors. So in the kids who don't respond, when I was saying that seizures can transition, right? Again, it's something about the developing brain between 3 months of age and 2 years of age that allows infantile spasms to happen, right? It's probably related, again, to brain chemistry at that age, the way the brain is kind of talking to each other, the connectivity. And so when that kind of matures, the seizures can kind of mature into tonic seizures. And if that keeps going, that hypsarrhythmia can transition to something called slow spike wave on EEG. And so the EEG and the seizures kind of transition together, and that's what Lennox-Gastaut is. And so that's why people say, infantile spasms is a risk factor for Lennox-Gastaut syndrome. Well, it's because those things are kind of maturing or morphing into Lennox-Gastaut syndrome over time. And again, the reason why we're actively investigating, right? Again, hard studies to do, you need at least 10 different centers. We're trying to do it now. It just, again, takes money from the government and a lot of convincing. And that's, again, when I'm not doing this, I'm writing letters, grants, trying to get it done. So it'd be great, right? And those who aren't responding, okay, we know they're not responding, we can try other things, but how do we prevent Lennox-Gastaut from happening? And Lennox-Gastaut syndrome was also 2 epileptologists who, in the 1940s, it was their names. One of them Dr. Lennox, one of them Dr. Gastaut. So that's where it came from. The history of this is always fun to try to think of. Those were epilepsy doctors, right? Dr. West, though, was a surgeon. Cool. Any other questions about this? Anything else? Happy to go off on any tangent if you guys want. Awesome. Well, how much time do we have? 20 more minutes, I guess. So the other thing I can kind of talk about, right? So other things that we're doing, right? So even if we don't find, just getting into genetic testing real fast, so there's lots of different types of genetic testing for epilepsy. The most common one that you'll probably hear about or talk about or see is something called an epilepsy gene panel, right? The other one you might hear about is a microarray. The other one is a whole exome. And the last one you might hear about is something called a whole genome. I like to think of these, so if you think of your DNA as a book, right? And you get one page from mom, one page from dad, right? We have, what, 23 chromosomes? So you get one page, you have 23 chapters, one page from mom, one page from dad. And so what we're doing when we do these tests is looking at the book and doing different things to understand if their spell checking is right. So I think about, you open Word on your computer or laptop or whatever and use some sort of software, word computing software program. The epilepsy panel is saying, okay, well we know there's 250 genes that we know are associated with epilepsy. And what it's saying is, in that book, 2 pages for each chapter, one from mom, one from dad. On page 5, paragraph 2, line 3, word 4, that's an epilepsy gene. We're going to use the spell checker and check it. And so this is what the epilepsy panel is doing. It's going through and 250 words, maybe the next one's chapter 7, paragraph 1, line 2, word 5. That's an epilepsy word. We're going to spell check that word too. Page 10, chapter 10, page 5, line 7, right? Same thing. You do that 250 times, spell checking. And what you're looking for is whether the words are spelled correctly. And if it's spelled correctly, great. If it's not, it is an epilepsy gene, and that might be the cause of someone's epilepsy. And then there's an in-between where maybe it's spelled differently, but just like there's some words in British English and American English that are spelled slightly differently, but you still kind of get the same thing, right? You can probably understand it, right? Sometimes they add E's in places we don't. So it's 3 kind of answers. Yes, it's a problem. 2, it's not a problem. 3, we don't know. The next test is a microarray test. This is looking to see if there's too many paragraphs, right? So let's say the words are spelled totally correctly, right? Just think if you had your own program operating, right? You had a spell checker. If the words are spelled correctly, it's not going to tell you there's a problem, but let's say you're missing a paragraph. So instead of 2-page ones, you just have 1-page one. Or instead of 2-page ones, you have 3-page ones, right? That can also be a problem. And so the microarray test is looking at whether or not you have too many pages, right? If you have 1 extra copy or one less copy. The epilepsy panel in babies and infants with seizures give us an answer about 30% of the time, 30-35%. In older kids and adults with epilepsy, it's about 20 to 25% of the time we get an answer. The microarray test, looking for those copy number changes in the pages, gives us an answer about 5 to 10% of the time. If those don't work, the other test we can do is called a whole exome test. So this is looking at all the words. So it's doing a spell checker for the entire book, and it's saying, okay, are all the words spelled correctly? This actually hasn't been as helpful anymore because now we know a lot of the different epilepsy genes, and so this only gives us an answer about another 1 or 2% of the time. So typically what I'll do is I'll do an epilepsy gene panel, and if that doesn't give us an answer, I'll go to the microarray. And just so you know, these 2 tests together are about half the cost of an MRI and about 2 30-minute EEGs. So they're not expensive tests. But insurance still makes you go through a bunch of hoops to get them done. So it can be tough to order, but they can be very helpful. Again, the problem is, I told you, in the best case scenario, 50% of people get a diagnosis on genetics, and at worst, 25% do. And so that means 50 to 75% of people aren't getting a diagnosis, even though we know genetics kind of plays some sort of risk. And so that's where whole genome is sort of the next step. The whole genome testing, so again, thinking about your book, the whole exome is looking at the words. A whole genome is not just looking at the words, but it's also looking at the spaces between the words, right? And you can imagine if there's too many spaces between the words, or let's say there's no space between the words, right? That's going to totally mess up the way you read it. And so that's what that's looking for. And we're still learning a lot about this. Our colleagues in cancer have done a much more they've had a lot more experience with this so far, and so this is where we're moving next, is in the people who we don't find an answer, where we're pretty sure that they have some genetic component to it, how can we potentially use this to help us figure it out using the whole genome sequencing? Not quite there yet, though. Almost. Great. Any other questions? Cool. Well, thank you guys all for coming. I'll be here, so if you see me around, feel free to stop by and say hello. Thank you.